This lecture is PTA103, Therapeutic Ultrasound Lecture for Semester 2 program. This lecture will be covering the various uses of ultrasound, the different types of ultrasound, and how it will be used in the clinic and will be used by PTAs to help treat patients with different Therapeutic ultrasound is an inaudible acoustic vibration of high frequency that produces either thermal or non-thermal physiological effects. It operates via the function of conversion, meaning it will convert sound waves into some other physiological effect that will help improve the overall healing of a patient. The ultrasound unit itself is going to come with two main components. The component one is going to be the actual unit itself. Those are actually the least expensive portions of the ultrasound units. The second part are going to be the applicators, which are these parts over here. These are the money. This is what costs the most amount of money because the piezoelectric crystal inside it is really expensive, so you have to be very careful with those. And main thing is, do not drop them. Ultrasound is acoustic energy. It's on page 380. It relies on molecular collision for transmission. So basically the sound waves themselves are going to go inside the body and cause the body's own cells to kind of bang off each other to create molecular displacement and create a vibration. So transverse versus longitudinal waves, right? A longitudinal wave is displaced in the direction of the wave propagation, travels in both soft and solid tissues. Specifically soft tissues primarily. In the solid tissue method, it doesn't travel so well through bone itself. The transverse wave then is displaced in the perpendicular to the direction of propagation. This only travels in solids, which is bones. So that means when you're dealing with this situation itself, the longitudinal waves is primarily your soft tissue waves. The transverse wave is the bone tissue waves. I'm going to say that again. Longitudinal waves are your soft tissue waves. The transverse waves are your solid tissue waves, primarily bone. So compression refraction we talked about during physics for those of you that had that class. Compression is an area of high pressure in the sound wave, whereas refraction is that kind of gap afterwards. You can often think of these as the refraction almost as the space between two peaks of the wave if it isn't binaural and actually come with two different waveforms. So frequency of wave transmission, the two different frequencies we have, right, comes in the 1 megahertz or the 3.3 or 3 megahertz. Audible sound operates in about the 16 to 20 kilohertz range. Ultrasound is in the greater than 20 kilohertz range, which means, again, you don't hear anything. Therapeutic ultrasound is 0.75 to 3 megahertz or over 1 million cycles per second. Lower frequencies have greater depth presentation, which is why I said. So the 1 megahertz unit itself is going to penetrate deeper than the 3 megahertz. Higher frequencies, more superficial absorption. That means that the 3 megahertz, it's going to be absorbed greater by the more superficial tissue, meaning the skin, the fascial layer, stuff like that. Whereas the 1 megahertz can get down and actually cause some cavitation on the velocity of transmission is going to be directly related to tissue density. At 1 megahertz, it'll travel through soft tissue at about 1,540 meters per second, through bone at about 4,000 meters per second. We talked about this before in physics as well. Sound travels much better through a solid object than through a non-solid object, such as water. Water is still greater transmission than air, but the solid is going to be our greatest transmission. So here's our different frequencies. As you can see, the 3 megahertz itself is going to have more waves per second than our 1 megahertz down here. So that means this is going to take and penetrate, this here is going to penetrate less deep than this down here. So your 1 megahertz is going to be for your deep tissue, 3 megahertz for your shallow tissue. Attenuation is a decrease in energy intensity. It decreases caused by absorption, dispersion, or scattering, and refraction and refraction. Basically what this is saying is the greater perpendicular you can actually get the ultrasound head to the tissue you're treating, the actual better the absorption is going to be, and the greater the energy intensity is going to be. Penetration versus absorption, here's kind of the breakdown of it. It is an inverse relationship. As absorption increases as frequency increases. Tissues in higher water content decrease absorption. Tissues in high protein content increase absorption. So the highest absorption rate is going to occur in bone, nerve, muscle, and fat. And this is important, especially looking at this nerve factor here, which is right down here. Because again, when you do ultrasound, if you should hit over one of the nerves, your patient will let you know it hurts. And one could even say it megahertz. Ultrasound at the tissue interfaces here. Some energy scatters due to reflection or refraction. Acoustic impedance, tissue density times speed of transmission determines the amount that is reflected or transmitted. The way you can think about this is depending upon what the actual impedance, so the resistance to flow, if you remember that from electricity, is, will determine how much is actually pushed through and how much is resisted. You can think of this a lot like your Wi-Fi in your home house. If your house is made of, thin, often wafer board walls, your Wi-Fi is going to have a better signal in the other room than it is going to be if it's transmitting through concrete walls. In a concrete wall, most of it's going to be reflected and actually is not going to penetrate the room that the Wi-Fi router is actually in. Most of the energy will be transmitted if the acoustic impedance is the same. The larger the difference in acoustic impedance, not acoustic, the more energy is reflected. So looking at this here, we can see the different forms of reflection here in this table that shows what gets reflected and what gets absorbed. Transducer compared to air is completely reflective. So that means if this transducer, the actual handle that you're producing with the ultrasound, is not directly on the skin, it will not go into the skin, and that kind of makes sense. That's why we have to use a conductive medium such as ultrasound gel. It does transmit through fat quite well, actually. Fat doesn't heat up as much as muscle, again, because most of the time it doesn't have the blood flow that muscle has. Muscle and fat interface, there is some reflection and refraction, and that's also due to the fascial layers that cover the muscle. And soft tissue, bone interface, it is reflected but can cause what's called cavitation at the bone level. We'll talk about that. It can create standing waves or hot spot areas. So here's the example. The angle that I fire that ultrasound off at will determine how much penetrates down into the skin. In this case, we're coming in at a 45-degree angle, which means some of it is going to get penetrated down at that 45-degree angle. Some of it's going to be refracted off here and not go in at the right angle. And then some of it, because of our angle, is going to be reflected back up into space, meaning that it will not get transmitted to the body. Your best option at this point is the ultrasound head coming straight into the body. Ultrasound generators, these are the actual machines. High frequency conducted generator that conducts that through an oscillator circuit and transformer via coaxial cable to a transducer. That transducer has a piezoelectric crystal in it, and the piezoelectric crystal will transmit that sound to the body. So you have to have electrical output that will cause mechanical vibration, that will cause the acoustic sound wave that will be absorbed in the tissue, that eventually will either cause heating or healing. Generator control panel should have a timer. It's important to let your patients know how long your ultrasound is going to go for. It should have a power meter, right? That should be your intensity and your megahertz. There's our intensity there control. Duty cycle switch. So if we should have on-off time, this is going to be our pulse versus our continuous, which is going to go along with this down here. And automatic shut-off time. This is important, right? If your ultrasound head shuts off for whatever reason and you can't figure out why, most of the time it's going to shut off due to it overheating. If it overheats, that typically means you are not holding the transducer perpendicular to the skin and or you don't have enough conductive medium. This is the one case where you cannot have too much conductive medium, meaning you cannot have too much ultrasound gel. You can always use too much of it. You can never want to use too little. There's our transducer applicator. It matches the individual's units and not interchangeable, meaning that if you have a unit for a BTL ultrasound, you cannot then use that BTL ultrasound on a Chattanooga ultrasound. They're design specific per manufacturer. It does house a piezoelectric crystal, which is what I talked about, right? I've repeated piezoelectric crystal multiple times. I might think that might be important for when it comes to your quizzes and your tests. So it is a piezoelectric crystal, which will transmit that sound waves into the human body. Typically, it's going to be made of quartz, lead zirconate or titanate, and maybe barium titrinate. It just depends upon what they want. Nickel cobalt is kind of one of the ones I see most common, and mainly because nickel cobalt is easily moldable and is less fragile than your quartz crystals up here. So, transducer face. This is if you're looking at the head head on, right? See what I did there? Head on. Your transducer face is going to have two different areas. It's going to have kind of the lead-in area here, which is this our darker brown area, and then it's going to have this inside area, which is your effective radiating area, right? Your effective radiating area is the only part of the transducer that is producing the sound waves into the human body, meaning out here at the transducer face, there's nothing being transmitted. So if we have a 4 centimeter total sound head, if that 4 centimeter sound head only has a 3 centimeter ERA, that means only that 3 centimeters is conducting the energy into the human body. And we're going to talk at this upcoming that, you can use the ultrasound head that would be 2 to 3 times, 2 times to 3 times your ERA. Meaning that in this case, this example here that I just gave with the 3 centimeters ERA, we could treat an area that would be anywhere from 6 to 9 centimeters squared as far as range. Anything greater than that, we may need a larger sound head or we may need to increase the area. It's going to convert the electrical energy of sound through mechanical deformation. So here's the piezoelectric effect in place. An alternating current is passed through it. It causes the crystal to express and compress. Oh my gosh. Expand and compress. There we go. A voltage will be generated at that point, and that's going to cause a direct electrical effect that's going to cause the sound waves to go into the human body. Indirect or reverse effect. As alternating current reverses polarity, the transducer crystal will expand and contract, producing that ultrasound. Again, with ultrasound, you are not going to hear the ultrasound. Your patient can't hear it. If they do say that they can hear it, yeah, no, they can't. Just tell them it's a non-auditory level that's above human hearing. Again, ultrasound. The effective radiating area we already talked about is the portion of the surface that produces the sound wave itself. Should only be slightly smaller than transducer surface. Most of the times it is going to be 1/2 centimeter around the sound head itself here. So this is about 1/2 centimeter of space on either side, which means your overall, if this is a 4 centimeter sound head again, on most sound heads, it's going to be reduced by 1 total centimeter or 1/2 centimeter on either side for the ERA. So here's a graph showing the temperature of ultrasound treatment depending upon the actual time in minutes. Meaning basically if you have a larger ERA sound head, right? So we're looking at a 6 ERA sound head versus a 2 ERA sound head. The 2 ERA is going to heat up greater because the electricity is being conducted through a smaller medium, right? Same idea with, if you were conducting electricity through a human body, something that conducts electricity with a smaller diameter electrode is going to conduct that at a greater velocity with the same impedance. So frequencies we talked about ranges between 0.75 and 3. Typically, you're going to see 1 or 3 megahertz. So again, 1, what I want you to remember with 1 is deep, right? So deep is 1. 3 then would be shallow, right? So you could think of, the deep one, this is going to be kind of like your Gandhi, and then the shallow, that's going to be like Paris Hilton. Ultrasound beam itself, right? This is showing the depth, right? Just with all modalities that we talked about, the deepest it typically goes is a 5 centimeter depth, no matter what the ultrasound head is. Even the 3 megahertz has a chance to go that deep. But if you look, because of the way the sound heads are designed, that's going to be an area of very, very low effect when you get past that 3 centimeter range on the smaller sound head. Whereas the bigger sound head itself is going to allow it to go deeper. And also, the 1 megahertz is going to allow it to go deeper. But effectively, once you go past this 5 centimeter area, there's not a lot of actual thermological effects with this, or physiological effects. The frequency is not intensity dependent, meaning that you can crank that intensity up all the way up to 5 watts per centimeter squared. I do not recommend this. Please do not do this. But that will not affect the depth of penetration. The only thing that affects the depth of penetration is changing the frequency. Again, changing the frequency will affect the depth of penetration. So if you need to go 3 to 5 centimeters deep, you need the 1 megahertz. If you're looking for, surface area down to 3 centimeters, you go with the 3 megahertz. The beam itself concentrates in a limited area. The larger or more heads are called a collimated beam, whereas the smaller heads have a more divergent beam, right? I think there was a movie a while back, I can't remember what it was called, but they were talking about divergent people. It may have actually even been divergent at this point now that I think of myself thinking about it. But the more divergent a beam, the actual greater the area is going to be spread, okay? That means that it's diverging from center, whereas collimated together. Near field distribution of energy is going to be non-uniform to the manner in which waves form. So that means that not all areas of the body are going to heat up the same way on that sound head. So there may be hot spots on that sound head. Points of maximal acoustic intensity. Waves are indistinguishable and arrive simultaneously, meaning the sound is going to travel at the same speed regardless of what waves we have. Energy is then going to be evenly distributed and the beam becomes more. BNR, beam non-uniformity ratio, indicates the amount of variability and intensity within the beam itself. Ratio, the highest intensity found in the beam relative to the average transducer intensity. Ideal BNR would mean that would be a 1-to-1, meaning that if it's delivering, 1 watts per centimeter squared, it's delivering that 1 watts per centimeter squared within that range at a uniform speed and time. So your BNR and your ERA, right? We talked about that already, the effective radiating area, can all be found on the tag of the ultrasound. Again, the ERA and the BNR can all be found on the tag of the ultrasound. Ideal BNR is going to be 1-to-1, but most are going to be somewhere in the 1-to-3 range. Again, this one shows typical 6-to-1. I believe ours are 1-to-3 if I remember correctly. PMIs are 5-to-1. I should have looked at that ahead. So here's what BNR looks like. So as you can see, on the outer areas, it's not as uniform as in here, which means that itself, this area here is going to be the area of highest intensity. Intensity is 1.5 watts per centimeter squared. The peak intensity within that BNR would be 9 watts per centimeter squared. So that means that's why we got to watch out for this. The lower the BNR, the more the intensity. We want it to stay within 1-to-1. Better generators have a low BNR that's provided more and even intensity throughout the field. BTLs typically, which is another brand of machine we use, Chattanooga's BTLs are a German brand. They tend to have a really, really low BNR. Most of them are between 1-to-2 and 1-to-3. Pulse versus continuous. This is the decision between heating and healing, right? So pulsed, you want to think of healing, right? That's pulsed. Continuous, I want you to think of heat. It's really bad right now, heat. So continuous, heat, pulsed, healing. And the way I remember this is the abbreviation typically for continuous is going to be CONT. Heat has 4 letters. CONT has 4 letters. Therefore, heat and continuous go together. That's the way I remembered it in school. You can remember how you want. But again, difference between heating and healing. Pulse is interrupted. Therefore, the intensity is going to be lower over time, meaning that if you have a pulse intensity of 10%, for every 10 seconds that machine is on, the ultrasound itself is only delivering energy for 1 second. That's the duty cycle, pulses per period, right? So duty cycle may be set between 20 and 50%. Some machines actually do down, and some are 5% depending upon if you're in a hand therapy clinic. Intensity is the rate at which energy is delivered in units per area. So spatial average intensity is going to be watts per centimeter squared. Power output in watts divided by the transducer space in centimeters squared is how it's calculated. So if we have 6 watts being delivered over a 4 centimeter sound head, that means it's going to be delivering at about 1.5 watts squared. There are no specific guidelines that detect this intensity. Again, guidelines for this, best option is to start lower and increase with time rather than starting up here in the high region and causing a problem with your patient and then having to back it down. Most machines start at 0.5 watts per centimeter squared and go all the way up to 4 to 5 watts per centimeter squared depending upon the machine. I have rarely seen anyone take over 3 watts per centimeter squared. Recommendation again is use the lowest intensity first and the high. Physiological effects, thermal versus non-thermal. Thermal effects, right? Tissue heating. Non-thermal effects, tissue repair at the cellular level. Average thermal effects or average effects occur within watts per centimeter squared of greater than 0.2 watts per centimeter squared. Meaning, if you put it at 0.2 watts per centimeter squared, if your machine allows for it, there will always be there will be no effect itself, right? Whether there is a thermal effect, there will always be a non-thermal effect. So what that's saying is, even if you're not on pulse, there will still be some non-thermal healing going on with that machine. Can help increase collagen extensibility, increase blood flow, decrease pain. All of these are thermal effects, reduce muscle spasm, decrease joint stiffness. Again, I often combine my ultrasound with a little bit of soft tissue work when I'm doing thermal ultrasound by using the transducer head almost as a massage device. Baseline muscle temperature is between 36 and 37. We can get mild heating. We can increase it by 1 degree. It'll increase the metabolic rate in the tissue, which is going to bring nice healing stuff in. Same thing with increases for 2 to 3. Vigorous heating is where we get to about the 3 to 4 region. And again, that's going to be similar to working out. At that point, we've increased the viscoelasticity itself. So here's rate of heating per minute. Again, as you can see, the higher this number goes, the actual greater the change in temperature is going to be, right? Do you see that? So setting at 1.5 watts per centimeter squared with 1 megahertz ultrasound will require a minimum of 10 minutes to hit vigorous heating. So for each of these, it's going to go up by that degree per minute. Okay, that is what the continuous is going to do. So here's clinical applications of ultrasound. We have our non-thermal, mild thermal, moderate thermal, and vigorous. The main thing I want you to know, again, is thermal is to help tissues extend, relax, calm down muscle spasms. You're looking for a heating effect. Non-thermal or pulsed is going to be for healing tissue. Typically, we're talking about ligaments and tendons. Increased fibroblastic activity, increased protein synthesis, tissue regeneration, reduction of edema, bone healing, and all this, and pain modulation are all examples of non-thermal effects of ultrasound. When you're dealing with these non-thermal effects, it typically is caused by the actual sound waves themselves propagating through the tissue themselves. What that means is it's going to excite those mitochondria and help everything. All the non-thermal effects of ultrasound occur through acoustic microstreaming and orientation. Microstreaming is when the actual sound waves here, you can see them, go into the cell and cause a unidirectional flow of fluid. That's why it's going to help that swelling act there. It's going to alter the cell membrane, permeate sodium and calcium ions, important in the healing process, right? It's going to help open up those sodium potassium pumps. Cavitation causes formation of air bubble gases that help compress due to the pressure changes in the fluid and help get any excess gases out of those cells, which can help push carbon dioxide and other things out of that. Stable cavitation results in increased fluid flow around these bubbles, which is good. Unstable cavitation, not good. Unstable cavitation results in violent, large excursions of bubble volume and often with popping. This can be really painful for the patient. We only derive therapeutic results from stable cavitation. This is kind of looking at what happens in stable cavitation, right? We cause these microcurrents to occur around the cell, which is going to cause gas exchange to occur more quickly and also cause nutrient exchange to occur more quickly. Here's unstable cavitation. We're actually going to cause these cells to kind of expand so much that eventually they're going to either implode or explode, which will then release the free radicals into the body, and free radicals equals bad things. That causes oxidation at the cell. Can be maximized while producing thermal effects, right? By doing spatial average intensity of 0.1 to 0.2 watts per centimeter squared with continuous ultrasound, duty cycle 20%, and maximize it. Application. Acute conditions require more treatment over a short period of time, 2 times a day for 6 to 8 days. We're typically going to not do ultrasound in the hospital because most ultrasounds or hospitals don't have ultrasound units. Chronic conditions, we can do it usually once per treatment. Limited treatments. So they do recommend that if you're doing ultrasound with a patient, you should not do more than 14 treatments of ultrasound with a patient. At that point, the benefits are no longer as effective, right? So that's what you want to pay attention to here. And I'm sure that some of you who do work in clinics will obviously probably own up to saying that you do ultrasound with a patient every single treatment, and they may have come more than 14 visits. Well, at that 14 visits, there are research that shows that after that, it's not really that. Treatment duration, size of the area to be treated. It's big. What exactly are you trying to accomplish? So we have to locate how big is the area we're treating and how big is the person. What are we trying to do? Are we trying to, again, heat or heal? the tissue. Does that make sense? And then thermal versus non-thermal effects, which is talked about, and then the intensity of the treatment. How much do we think that patient can tolerate on the intensity level? Again, better to start low and work our way up. Size of the treatment area should be 2 to 3 times larger than the area of the ERA. So again, I'm going to repeat this. This might be important. Treatment area with ultrasound is 2 to 3 times the ERA. Right? This is very similar to ice massage. Ice massage is 2 times the size of the ice cup. But the ice cup doesn't have an ERA. Ultrasound does. Where do we find the ERA again, folks? That's right. I'm glad that you said that. We find it actually on the ultrasound tag for the sound head. If the area is to be treated in larger, right, use shortwave diathermy. Yeah, that's not going to happen. We don't have those very often. We could use superficial hot packs. Right? So for example, the low back. We can do ultrasound on the low back, and we will practice that. But more practically, the hot pack is going to be better. Again, we're going to get similar effects. Or hot whirlpool. Again, most clinics don't have that anymore. So here's the difference in intermuscular temperature, right? So we look at this. A hot whirlpool increases by 1.1 degrees. 3 megahertz ultrasound may increase by 4. But after 10 minutes, they pretty much stay about the same. Intensity recommended for specific intensities makes a little sense. Ultrasound intensity should be adjusted to patient tolerance. Increase the point where there is warmth, and then back down until there's general heating. So you're going to want to turn the intensity up until the patient can feel some warmth. And then once they state that they feel warmth, we're going to back it down ever so slightly. Take it down by 0.2, 0.5 megahertz. If you decrease the intensity during treatment, at that point then we have to increase treatment duration because our goal is to deliver energy to the area. If we decrease the overall intensity, treatment intensity or duration needs to go up. Ultrasound treatment should be temperature dependent, not time dependent, meaning you want the whole tissue to warm up. We don't care about how long what we do for billing, but we don't have to worry about it as much. Energy reflection is great at the air-tissue interface. That means we need to minimize air and maximize contact with the tissue, so we're going to use a coupling agent, which is typically gel, water, mineral oil, something to that effect. We can also use analgesic creams, right, such as any type of, not antibiotic, but steroid type creams or anything like that, but gel ultrasound is typically what we're going to use. Seems to be the direct contact ultrasound means we're going to use the gel, and the transducer itself is going to be in direct contact with the skin. It needs to be at 90 degrees or perpendicular to the skin. Again, gel needs to be applied more liberally. That means it must stay in contact with that gel at all times, meaning you have to move that gel in. Heating the gel does not increase the effectiveness of the treatment, so warming up the gel is just the patient comfort with the actual treatment. Here's ultrasound being applied to the heads of the hamstring. Immersion techniques or underwater techniques. We're going to use water as the actual treatment medium at that point. We can use a plastic bucket, we can use a basin, we can actually even use a tub if we have those. Tap water is useful as a coupling medium. Again, water transmits sound better than air. So water will still allow that to transmit to the body. It should be moved parallel to the surface at about 0.3 to about 5 centimeters. So that means you want it less than 2 inches away from the skin. Right? I'm going to say less than 2 inches away from the skin. Air bubbles should always be wiped away if they're noticed on the sound head because that's creating cavitation actually at the sound head itself. The intensity should be increased possibly as much because water does not transmit it as much. This is the bladder technique. So bladder technique, we're going to use some sort of a medium. Typically what we're going to show is using a glove with gel on either side of it, but this here is actually a traditional actual bladder that you can buy for ultrasound. But we're going to use a water-filled substance like a glove, a bag, something to that effect to conform to the area we're trying to treat when we're having something like this case, the lateral malleable, because it's not a very uniform surface. Either side of that medium, then, either side of that bladder has to have ultrasound gel on it in order to transmit it. Good for irregular surfaces. Use a bag filled with water. Both sides of the bladder, again, should be gel. Moving the transition. Stationary technique is no longer recommended. You can actually burn the patient. Here, the applicator should be moved at about 4 centimeters per second. If you remember back to ultrasound, or not ultrasound, ice massage, it was 5 centimeters per second. Here we're talking about 4 centimeters per second. So they're very similar in treatment techniques. That's why we do ice massage first, so you can learn how to do it. Low BNR means slower movement, meaning if your ratio is a high BNR, you have to move it more quickly, or otherwise you can end up with that attenuation problem. It can cause cavity, osteal irritation. Stroking technique, we can move it in circles, we can move it in kind of the snake technique. The only main goal I want to say here is that anytime that ultrasound head is on and in contact with the patient's body, it needs to be moving. You need to move it. Other modalities, ultrasound cooling tissue does not facilitate an increase in temperature. That makes sense. You don't typically want to use cooling right after ultrasound because you just kind of interfered with the actual perception of heating at that point. Ultrasound and EMS is useful to treating myofascial trigger points. I mean, ultrasound with electrical stim is very useful. Ultrasound is clinically widely used modality in treatment of soft tissue and bony problems, right? We've talked about this. There's relatively little document reflecting this evidence. So basically, if we look at soft tissue and bony lesions, there's a lot of people that do it, but we don't have a lot of evidence that shows it works. Most of the data is unequivocal. We don't have that great of a data on it. During the inflammatory stage, cavitation and streaming increases transport of calcium across membrane, meaning that we can actually stimulate leukocyte histamine production to help clean up the area. So you can bring in those eaters of the dead, clean up the area. Scar tissue and joint contractures, increased temperature can actually increase the elasticity of those tissues and decrease the velocity or the viscosity of those collagen fibers. Meaning if we use ultrasound on a scar that we're worried about becoming keloid, we can actually help it heal better and maybe prevent it from becoming an immobile scar. Chronic inflammation. There's almost no information out there about it. It does not seem to be effective in increasing blood flow for heating or healing these chronic injuries. That means really in the physical therapy world, most times we're seeing patients for chronic injuries. I mean, we do see them for acute injuries, but that should be the only time we use ultrasound. If they're a chronic patient, we shouldn't really with them. Bone healing. Ultrasound does increase fracture repair once that callus has formed. So that means we have to have a functional callus at that point, otherwise we can cause cavitation at the bone and it can be painful. It can also be effective in detecting stress fractures because if we use ultrasound on a bone that we think might have a stress fracture, usually they're going to let us know it's a fracture because it's pain reduction. Not really useful for specifically reducing pain. The thermal effects actually can help increase the function of free nerve endings, can either increase or decrease pain as it may affect gating, especially if you use the massage technique while you're actually doing your ultrasound. It does increase conduction velocity. Again, at the peripheral level, nerves actually conduct better at high temperatures, whereas at the central level, it typically conducts better at low temperatures. There have been a number of studies that show placebo effect in patients using ultrasound, basically meaning that if the clinician believes in ultrasound, often the patient believes in ultrasound. Phonophoresis is ultrasound-delivered topical medications and selected medications on tissue. It's different than iontophoresis, which is using e-stim for it. The main difference here is that phonophoresis, we don't have to worry about the polarity of the medication we're delivering. We just have to worry about delivering that medication to the skin itself. Anti-inflammatories, cortisol, salicylates, all of this can be used to help it. Analgesics as well. Non-thermal effects increase tissue permeability. That means when we're delivering ultrasound or phonophoresis, we should be using a non-thermal or pulsed effect. Early studies does demonstrate effectiveness in penetration with it, right? More studies show ineffectiveness. A lot of studies show that iontophoresis is actually better for delivering the medication than phonophoresis. So here's that type thing. So here's our indications: acute and post-acute pain, soft tissue healing. You guys can read through this. I'm not going to read through all of these. What you guys think about is contraindications. What are my contraindications? Decreased sensation, decreased circulation are all contraindications. Vascular insufficiency, anything dealing with the veins, thrombophlebitis, blood clots. You don't want to do it over the eyes or the reproductive organs. I shouldn't have to say that, but for some reason I still have to say that every time we do it. Pelvic area following menses, meaning that when the woman has had her period, we don't want to do it immediately following that. Pregnancy, again, I should have to say this, but you don't want to ultrasound babies. And pacemaker, mainly because you can cause a pacemaker to go out of sync with the heart, and we don't want that. That is bad. Malignancy is cancer, right? Anytime we have a cancer suspicion, we don't want to deliver energy to that area, increase it. Epiphyseal area for children, these are our growth plates, right? That's what allow our bones to grow, right? So growth plates. We really don't want to do ultrasound over the ends of bones until the person has reached, maturity where they're actually not having those growth plates. Total joint replacements, especially if they're metal or any infections, we don't want to. So this is your typical SOAP note. We'll actually do one in class. If there are any questions on this lecture, please feel free to contact me. This has been the ultrasound lecture. Thank you very much.